more on the procedures. Where else do we go from there?
Well, I think the way to think about blood management and bloodless medicine and surgery is that it's not just one procedure, it's a whole process. It's getting the patient prepared for surgery by correcting any anemia to get the blood count up so that there is room for some blood loss. Secondly, to use techniques that minimize the amount of blood loss at the time of the surgical procedure.
Such as?
Well, such as using electrocautery, using various... Electrocautery.
What is that?
It's an electrical device that seals over bleeding blood vessels so that when they're cut, they're also sealed and there's minimal blood loss from them.
Okay, real quick, jump back in, because I don't want to ask about pregnancy, because this is a very important issue here. Yes?
No, it just, again, I think that we can't overemphasize the fact that you could divide patient blood management, including bloodless surgery, into three sections.
Three sections, go ahead.
The first one is preoperative.
Pre-op.
Preoperatively is detecting and diagnosing properly the anemia. As Dr. Goodenow described, in many patients, their anemia is ignored, and they are behind the 8 ball when it comes to surgery where there's significant bleeding. So that taking care of that is essential.
If you don't?
If you don't, you're going to bleed and you're going to be at risk of being transfused. The highest risk of transfusion in surgical patients is having anemia preoperatively.
And the pre-op process can pick that anemia up and...
Without question.
Got it. Next phase.
The second is intraoperatively, is not letting blood shed. Cautery is one we just described, sealing the blood vessels, making sure they don't bleed continuously during surgery. And if they do bleed continuously, collecting the blood, washing it and returning it.
Washing it and returning it.
The cell salvage process we just described. The other things are there are some drugs out there that can actually reduce the amount of bleeding that can be added to the mix, if you will, during surgery, so that the amount of bleeding is reduced. And then lastly...
So back up, stay on the drugs. Are we talking about drugs that stimulate the production of red and white blood cells and platelets?
Those are the ones that we use preoperatively, and I will address those postoperatively. Intraoperatively, these are drugs that help clotting.
That's so during the surgery?
Correct. Just as you mentioned before, electrocautery or the cauterization of vessels, we can also add drugs that may help you clot. And then lastly is once the patient is out of surgery, they now have lost blood. Now the therapy, again for anemia, has to be addressed, and has to be addressed effectively and early on.
Wow. I'm realizing as we're talking about this, I mean, I've had several medical procedures and surgeries, and I'm realizing that I haven't come close to the kind of detailed description, no disrespect to the surgeons involved, but is this on a patient to say, doctor, before we go any further, let's talk? Is it on the patient, the doctor? I mean, who's supposed to drive this? Because this sounds like a pretty complex, multifaceted, but most importantly, critical conversation.
Well, it's important to have a coordinated program like at Englewood Medical Center where you have a multidisciplinary team, surgeons, anesthesiologists, critical care specialists, transfusion medicine specialists who are comfortable with the concept of bloodless medicine. And by the way, this is an important tool for hospital disaster planning. When I run a blood bank, and most administrators are fastened on acute events like hurricanes or earthquakes where there is a blood surplus because nationally everybody wants to help and they donate blood.
Right.
If you have a slow rollout pandemic like the 1919 flu or the swine flu, for example, over many months where the general public is either about to get sick, they're taking care of somebody sick, they're sick or they're recovering, they're not going to be interested in filling our donor chairs and donating blood. And yet healthcare delivery needs go on. Trauma, postpartum hemorrhage, labor and delivery hemorrhage, sure. Elective surgery, non-elective surgery, healthcare needs go on. So how do we support those healthcare needs without blood in the blood bank? That's where bloodless medicine comes in. You need a team that's in place and comfortable and coordinated delivering healthcare without blood.
Doctor, here's what I see you saying. There are two messages. One, and it's interesting, we're doing this program after the horrific situation in Haiti. We're doing it toward the end of January 2010. We happened to go with our kids to the local Red Cross in our town, and it was packed in terms of people giving blood. They were involved in a serious blood drive. And those are the incidents that you say generate that reaction. but there are others that don't. Two messages. One, that the blood supply is never what we need it to be. Is that fair?
That's correct.
But there's a second one, which is that given that the blood supply isn't where we would like it to be for a variety of reasons, that these bloodless options are more critical. Fair?
Absolutely.
So let's talk pregnancy and childbirth. What are the blood-related issues here, doctor, that are so critical?
Well, they're very similar to blood issues in any surgical condition, but what you need to know that the public probably doesn't recognize is approximately 5% or 1 out of 20 pregnancies is complicated by excessive blood loss, usually at the time of delivery. And that means that 5%, 1 out of 20 women, is at risk of requiring a transfusion at the time of delivery.
1 out of 20.
1 out of 20. Now, all of the things that we've talked about apply. That is to say, correction of anemia prior to delivery. Anemia is very, very common in pregnancy, but it needs to be attended to and corrected in case that woman is one of the 1 in 20 who might lose excessive amounts of blood at delivery.
Are we also saying here that we need alternatives to transfusions?
Well, I think...
Isn't that another important message here?
Yes, I think that that's a goal that we're probably
because of the risk associated with transfusions.
Correct. There's some other levels, though, that I think we need to address before we go to the creation of alternatives. And the blood conservation or the blood management that we're talking about. Here's, you know, Mrs. Solomon's got the experience of being able to have serious surgery without being exposed to allogeneic blood, that is bank blood. There are, again, is a slew of experiences like that out there. So we know we can perform these surgeries, complex surgeries, without the use of blood by using these alternatives or these systems, if you will, that were described. On the other hand, we have another issue in terms of what Dr. Goodnow was addressing is the availability of blood components. If you look across the nation, there are some hospitals that have a transfusion rate for cardiac surgery, say, which is less than 10%. And there are other hospitals that do the same surgery and have a 90% transfusion rate. This discrepancy, again, has to do with a cultural background and, again, the not having the systems, if you will, to be able to reduce the use of blood in these institutions. And we all talk about the donor population and trying to get donor population in terms of extreme shortages, but I think we need to start looking, as you mentioned before, the alternative would be, again, is to have the same credence and importance to blood conservation, because that is a constant and a continuous effort, which again would reduce the usage and will put a lot less pressure on the blood supply.
Let me ask you something, Mr. Solomon. Obviously, both of these significant procedures, one in 1995 and the other one in 2009, you would have rather not have had to deal with, obviously. Yes. Your family, those closest to you, what kind of conversation did you have with them about all this?
Well, there were many, I could say, hours that we spent because from 2006, when I first got the infection, remember I didn't get this major surgery until 2009. So we were talking constantly, my wife and I, you know, about the situation of the operation and what could possibly happen. I mean, something either other than blood could have happened while I was on the table. But basically, they were all behind me, and that meant a lot. But again, like I said, knowing the hospital and the staff that I was going to use, that took a lot of pressure off of myself and my family, because they felt that the hospital would have no problems complying with our wishes.
Let me ask you something. I want to clarify something. What does the medical research show us with respect to transfusions and patient outcomes? What does it tell us in terms of whether blood transfusions do in fact have the potential to make things worse for certain patients? Let's talk about it.
Well, there's an emerging body of evidence to suggest that there is a downside to blood, especially when you have to give a lot of it to critically ill patients. On the short term, it may very well be life-saving, but long term, we're learning that many of the organ failures associated with either the trauma or the blood transfusions or both have long-term consequences. And so that's where blood management comes into being. Support the patient, resuscitate the patient, get them through their critical care illness with the goal of minimizing blood transfusions.
Jump in here, doctor.
I think what the literature would show is that there is a small percentage of men and women who are absolutely helped by transfusion. Then there's a small percentage at the other end of the spectrum who absolutely are harmed by transfusion. And then there's a huge gray area in between where we don't really know how much benefit patients are receiving from transfusion.
Do we, doctor, have some reticence, discomfort as a society, as a culture, to talk about blood and blood management just because, I mean, I know for me growing up, some of the, I remember getting bit by a dog when I was 10 years old and the blood was all over the place and it was traumatic, right? Sure. Other than the fact of being afraid of dogs, it had an impact on the way I view blood and the squeamish nature, our attitude about blood. Does it impact, I don't want to make too much of this, but I do think about it, that we're uncomfortable talking about blood?
Well, there may be some element in terms of the public being uncomfortable, especially with a bleeding episode.
Not in the medical community. I'm talking about for consumers, for patients.
Less so. I think it's actually more emotional topic with the medical community than it is with the public.
Really? Why is that?
I think because, as Dr. Friedman mentioned before, there's an enormous amount of tradition. It is still what we consider to be a default position, that when in doubt, give blood.
When in doubt, give blood.
Right.
And the downside of that?
The downside is the fact that the patient may actually do better without receiving blood or any other component of blood. And just to show that discrepancy in terms of what I just mentioned in terms of cardiac surgery, less than 10% and 90%, you could see that there is probably the truth lies somewhere in the middle. So
blood is best is not always the way to go here.
I think that that's a very good statement.
Let's do this in the couple minutes we have left. Which procedures, from the experience we've had as relates to bloodless surgery, which procedures are most likely to have the best, the most positive patient outcomes? Let's go through it. What do you got?
Well, we have a lot of data in terms of cardiac surgery.
Cardiac surgery?
Yes, with extremely good outcomes when the transfusion rate is lowest.
Okay, give us another one.
Any procedure where you can plan ahead to allow you to have time preoperatively, especially, to mobilize the tools we've talked about to help get the patient through. Why do we have a national blood inventory? It's really for people who can't plan ahead. Trauma cases, labor and delivery hemorrhage, non-elective surgery, malignant hematology like acute leukemia. So there's a role for a national blood inventory, but for everybody else who can plan ahead, that's where blood management and bloodless medicine are so important.
Final comments?
I just think that all of us in the medical community as well as the public need to open the lines of communication and aim toward optimal management.
Great job, everyone, particularly Mr. Solomon. We appreciate you being with us.
Thank you.
If you would like more information on this program, or if you'd like to express an opinion, email us at info@caucusnj.org and visit us online at caucusnj.org. The preceding program has been a production of the Caucus Educational Corporation, celebrating over 20 years of broadcast excellence. NJN Public Television, and 13 in association with WNET.org. Funding for this edition of Caucus, New Jersey has been provided by Englewood Hospital and Medical Center, Verizon Communications, QualCare Inc., a local managed care company covering 750,000 New Jersey residents, and by New Jersey Natural Gas, proud to support education in our communities. Promotional support provided by NJ Biz, all business, all New Jersey. Transportation provided by Airbrook Limousine, serving the metropolitan New York, New Jersey area. Caucus, New Jersey has been produced in partnership with St. Joseph's Healthcare System.